Hey everyone, this is Ryan Balmes. Thank you for listening to the Ryan Balmes podcast and YouTube channel, watching online, where it is my goal to help clinicians become better clinicians and truly enjoy their clinical practice. Now, in episode 4 today, let's talk about modalities. All right, I'm going to make this quick. I use modalities, and I think there is a way to use them, I guess, in the most evidence-based way possible, if that's a thing. I think modalities get a bad rap. Let's just be honest with that. I used to be that guy in the clinic. Oh, you shouldn't use them at all. There's no evidence behind it. And sure, there probably isn't. But there are just some things to our disposal as physical therapists, physical modalities that we can utilize to help as an adjunct or even help get therapy in our sessions moving. With modalities, let's go with ice and heat. I literally look at them as just feel goods. They are the candy of what we do. They're nice to have, but they're really not that necessary. Now, if a patient requests it, once appropriate, I'll give it to them. Will I use it with some patients? Absolutely. But I'm being strategic with it, and not everyone gets the same modalities, and I think that's the one big thing too. When you think about the most high value interventions that you could do with your patient in the session, modalities is probably the lowest value of the list. We know in terms of the long term, again, going back to my first episode in terms of value-based care, what will get you to be the most higher significant change in outcomes will be active treatments for that patient. But passive modalities do have a place in what we do. Ultimately, in the world according to me, I use modalities to decrease irritability. Now, irritability is a concept that I learned in residency. So irritability is the patient's response to pain. You have patients that say, oh, I have a high pain tolerance. Well, their irritability will then be low. For those that have a low pain tolerance, or even where the mechanism of injury doesn't quite match the intensity of the patient's reporting pain. Remember, the pain is still very real. I would say that their irritability is high. It's going to be related to the other notion called severity. Severity is related to the actual tissue healing and where it is in the process from the injury. So if you sprained an ankle yesterday, the severity of those tissues are pretty high the next day. This goes back in terms of maybe the chronic pain situation where the irritability is high, injury happened a year ago, severity of the actual tissues, let's say the muscles and joints, are low. That gives us an idea that I could probably load or do more active exercises with that patient because I know the severity is low. The likelihood of re-tearing or doing something like that is low. The pain is still very real, but the severity is low. Hopefully that makes sense. So with modalities, I use it as a gateway and candy to decrease irritability. Case in point, if I have a auto accident neck pain patient, modalities there would maybe be a good choice, especially if you're seeing the patient soon after the accident. Irritability is high, let's say in high pain, and severity is pretty high. High to moderate, right? Tissues are going through their initial shock phase and healing from an injury or car accident, and the thought of maybe doing, 30-pound rows, or even the concept of even trying to do that, it's pretty far reach for maybe that patient. You would have to work up to that. So modalities like heat and electrical stimulation, like inferential current, you could use that as a way to decrease irritability and then get your active treatments going. The one thing that I see is a common mistake with students and even colleagues is when you use the modality, just go ahead and be hyper blunt about why you're using it. I've learned in my practice that patients aren't dumb. If you are completely honest with them, they appreciate it. And again, going back to my last episode, which I hope it made sense, your words matter in terms of what you say. So if I go with the patient and say, hey, today, I know you're still in a lot of pain. Let's go ahead and get a hot pack and some electrical stimulation to the neck to decrease that pain. And hopefully they'll be able to give us an opportunity to do a little bit more in treatment today. Does that sound okay? Now listen to what I said. I did not mention anything about inflammation. I didn't mention anything about getting tissues looser. I didn't mention anything about healing anything, because I know it does not heal anything. It is literally a candy for pain. It makes the pain go down. And that, in its sense, will give you the opportunity to get your active treatments in. Chin tucks, rows, stretches, whatever you would like. Active treatments, because without it, any of those active treatments that you had planned to do, it would just be very difficult. And for someone that's in a lot of pain, and then you may be causing them more pain with these active exercises because their irritability is very high, their trust in you and rapport will go down like crazy. It will plummet. So that's how I use my modalities. You could also use modalities as a feel-good after. And even then, I'm not mentioning anything in terms of, oh, we're improving recovery or we're letting the tissues recover. I'm literally just saying you're going to feel sore, so go ahead and put an ice pack just for it to feel good. I'm hyper blunt about it. Use these modalities to feel good. And that's really my soapbox on how I use modalities: ice, heat, electrical stimulation. You're using it as just another way to get the irritability down, to buy you more opportunity to get your active treatments in. All right. Thank you all for listening. Like and subscribe on the YouTube channel, and subscribe on the podcast. And again, share with 3 of your friends and colleagues who you think would benefit from this content. I'll catch you guys on the next one. Bye.